We'll continue our vital signs with respirations. Now, respirations is the act of breathing. It's the exchange of oxygen and CO2 between the atmosphere and the body's cells. So one respiration is going to consist of one inhalation and one exhalation. So inhalation, your diaphragm contracts, it moves down, it pulls air in. Exhalation, the diaphragm relaxes and it moves air back out. That would be one breath. When we're looking at characteristics of respirations, one is we count our rate, and our rate is going to be, a normal adult rate range is 12 to 20 breaths per minute. So that's the number of respirations per minute an adult will usually have. Rhythm is the breathing pattern. Is it regular or is it irregular? So for instance, children generally, toddlers, they will breathe at a real irregular pattern. They may breathe really fast, and then they slow down. You'll also see the rhythm change with your respiratory patients, like your COPD patients, patients that have chronic obstructive pulmonary disease. Sometimes their patterns can get really irregular. The depth, the volume of air that's inhaled and exhaled, it's usually described as breathing shallow or breathing deep. So normal respiratory rates for newborns, it's 30 to 50 breaths per minute. For 1 year of age, it's 20 to 40. For 2 to 10 years of age, it's 18 to 30. And then once you get those adult range, as you're getting to be around 11, 12 years old, you start getting more into a normal range. But 11 to 18 is still 16 to 24. Adults, 12 to 20. Now, they don't give us a rate range for our elderly adult. But just so you know, our elderly adult, not unusual to see them at 20, even 22, and we don't usually get too upset, even though the adult range is considered 12 to 20. So when we're counting respirations, you want to keep your patient unaware of what you're doing. So if I tell you I'm going to count your respirations, you're going to automatically start thinking about your respirations, and you're going to modify them. They'll either become slow and regular, or they'll become a little bit more fast and a little bit more shallow because you're thinking about them. So we want to keep the patient unaware of what we're doing. And the way we do that is we're going to keep our fingers on their pulse. So when we're checking that pulse, so remember on the inside of the thumb, the radial artery, when we're checking that pulse, and we said if the heart rate was regular, we could count for 30 seconds and multiply by 2. So we can count the heart rate for 30 seconds, and then we're going to keep our fingers there, and then we're just going to switch over and look at the chest and start counting that. And so hopefully they'll still think we're checking for the fingers. You count each inhalation and exhalation as one breath. And so we're going to count our respirations for 30 seconds and multiply by 2. We count for a full minute if they have respiratory issues or if it's for a small child. Now also, if you happen to get the skill for state competency, it is also counted for 1 full minute. And it's a little different for state competency. For state competency, they'll you can actually tell them I'm counting your respirations, where on a regular person you would not. You would not want to count respirations right after exertion. If I get up and I start exercising, my breathing is going to get faster. So I don't want to count it as soon as the person gets back into bed. I want to give them time to settle down, so I'm getting a resting measurement. And when we record the respiratory rate, we would also want to note if there's any abnormality in that rhythm and that depth. Is the breathing irregularly patterned? Is it really shallow or really deep? Are they having any unusual things with their breathing? So things that can influence our respiratory rate, well, pain can. Pain can speed it up because it's going to make us really uncomfortable. Allergic reactions. Allergic reactions can cause a person to breathe very fast, and as their airways swelling up, it can cause them to really struggle and use all their extra muscles to help them pull air in. It can also eventually slow the breathing down and stop it if we don't take care of the issue. Exercise. Exercise will cause our breathing to speed up. And medical conditions, if the person has a respiratory issue, if they're having an allergic reaction to something, that can make things speed up. If our patient's been taking a lot of medications, a lot of narcotics especially, it can actually slow our breathing down. So there are some terms that are related to the respiratory rate. Excuse me. Related to the respiratory rate, Pena, P-N-E-A, is the root word for breathing. So an A in front of it, when you have A in front of the root word, it means absent or lack of, so temporary sensation of breathing or lack of breathing. Brady in front of a word is slow breathing, or slow. So bradypnea is abnormally slow breathing, so it would be less than 12. Dyspnea, D-Y-S, in front of a word is difficult or painful. So dyspnea is difficulty breathing. Orthopnea is difficulty breathing when laying down. So that means the only way they can get comfortable and feel like they're taking in enough air is if they're in a sitting upright position. Tachypnea, and actually with orthopnea, sometimes people have to sit upright and almost actually lean forward, like lean over a table. Tachy in front of a word is rapid, so tachypnea is rapid respirations. Now, breath sounds should be quiet. You should not be able to hear a person breathing without a stethoscope. So it should be no noticeable signs. So if I was teaching class and I heard you breathing in the back of the classroom, that would tell me something is wrong with your breathing. The term stridor is a really harsh sound on inspiration. So that would be a stridor, a really harsh type of noise when the person's trying to inspirate. Crackles is fluid accumulation. So if you take your hair and you just kind of rub it right here by your ear, kind of reminds me of what crackles sound like. Rhonchi is gurgles or rattling, and you're going to hear that sometimes when we're in the nursing home and we're feeding our residents and they start coughing, or if they have any type of secretions, they have just kind of, you can just hear things like mucus and stuff rattling around in the chest. And wheezes are high-pitched whistling noises. So those are all abnormal sounds. When a person is just laying down breathing, you shouldn't hear anything like that. The other thing with breathing, too, that I want to mention is breathing, if you see them using all their muscles in their chest, so you see them breathing and they're like having to like use all their muscles to try to help them pull air in, that is obviously a sign or an indication that there is a problem as well. Now, blood pressure is the amount of force against the walls of an artery by the blood as the heart contracts and relaxes. So basically it's telling us how hard's our heart having to push to get blood everywhere through the arteries. And there's two phases to our blood pressure. There's a systolic phase and a diastolic phase, because there's two phases to our heart. When our heart contracts, that is systole, contraction phase of the heart. And so when your heart contracts, the left side of the heart contracts blood and ejects it out to the body. The right side of your heart, so actually your right and your left ventricles contract at the same time, but the left side is pushing blood out your body, the right side is pushing blood over to your lungs. That is the time of greatest pressure because your heart's in its working phase. The diastolic phase is the relaxation phase. So diastole is relaxation phase of the heart, and that's when the ventricles are filling with blood. So the left ventricle is filling with blood, so it can pump over to the heart, to the body, and the right side of the heart is filling, so it can pump blood to the lungs. This is the time of least pressure. So when we check blood pressure, there's two values we're looking for: a systolic phase, a systolic blood pressure, and a diastolic blood pressure. So normal blood pressure values for an adult, it is 90 to 120. That is the systolic range, 90 to 120. The diastolic range, the resting range, is 60 to 80. So the thing is we don't really consider things hypertension, high blood pressure, till we get over 130. So that 120 to the, when we're looking at over 121 to 130, it's more like a pre-hypertensive state. It's usually not anything we worry about too much. We just kind of tell people, hey, decrease your stress, quit eating sodium. If you're overweight, lose some weight. But we do consider it hypertension when the diastolic is over 80. Children's ranges vary by age, but they are lower. So their heart rates were faster than an adult. Their respiratory rate is going to be faster than an adult, but their blood pressures are lower. And elderly adults tend to have a tendency for what we call orthostatic hypotension. And we'll talk about that in a little bit, but that's basically when an adult gets up too quickly, when they go from a lying down position to a standing position, and their blood pressure drops, and they feel dizzy and lightheaded, and and they feel like they're going to pass out. Sometimes they do pass out. So it was one of the reasons why when we talked about our moving a patient safely section, we talked about when you're getting a person up, it's a good idea to just sit them up and let them adjust for a little bit. Dangle them on the side of the bed, let them adjust for a little bit, stand them up. Don't just expect them to pop right up out of bed and get moving. So some general guidelines when you're taking blood pressure. We want to do this when the person is lying down or when they are sitting down. The only time we do it when they're standing is when we're doing those orthostatic vital signs, which we'll talk about in a few minutes, and then we do it lying, sitting, and standing. We want to position the arm level with the heart and make sure the arm is supported. So if you were doing blood pressure for me right here, my arm would be supported on this table. You don't want the person to just hold the arm up like this, because they're contracting muscles. They're, it's going to alter your blood pressure reading. You want to make sure you have the appropriate size cuff. Now, I think there's a question in the workbook pages in your book, and it says, how would you know if you had the appropriate size book? And I think the answer they're going for is you could check with the nurse. I'm going to tell you, as a nurse, as an RN, I would expect you to know to tell if the blood pressure cuff is too small or too big. So when you look at a blood pressure cuff, this part of your blood pressure cuff is called the sphygmomanometer. Okay, this is the part that you're actually reading. And it's read in millimeters of mercury. So millimeters of mercury. So when you're looking at this blood pressure cuff, you'll notice here that there is a white line here. It's called an index line. Okay, so on my blood pressure cuff, I have this white line here called an index line. On the inside of the cuff, there's these two white lines over here. And it says minimum and maximum. So when you put this around someone's arm, and this is coming around their arm, this white line here, this index line, should be in between these two lines. If it's not, there's a problem, okay? So if you're putting this cuff around them and it doesn't come within these index lines, so you kind of, you can see these two white index lines here. So if I'm putting this around the person's arm and it does not land in between those two index lines, if it closes off before the index lines, it's going to tell me, select smaller cuff. This cuff is too big for that person. And if you take a blood pressure reading with a cuff that's too big, it can give you an abnormally low reading, a reading that's lower than what it should be. On the other end of it, if their arm is so big that when I put this around and it's not even coming into those two white lines, it's coming all the way over here, then it's telling me that, it tells me here, select a larger cuff. Because that's telling me that this cuff isn't big enough to go around their arm properly, and that's going to give me a false high reading. So you need to make sure you have the right size cuff, and they make cuffs from small infant size to bariatric large patient size. If you're using an electronic machine, the numeric values are going to be displayed on the screen, but when we're using a manual blood pressure cuff, you need to be able to read your sphygmomanometer. Now, for state competency, they, depending on what state you're in, so for California, for us, we have to do manual blood pressure cuffs. So we have to be able to do a manual blood pressure reading. So this is what our blood pressure cuff looks like. So this here is called the sphygmomanometer. This is the bulb that we pump up with. This is a little, just like a little piece of material that you can actually latch this onto so it's not falling or rolling around. Now, a lot of these have two arrow lines to them. So if I'm putting this on the right arm arrow is going to go over the brachial artery. And if I'm putting it on the left arm arrow is going to go over the brachial artery. When you're looking at this sphygmomanometer, again, it's read in millimeters of mercury. When all the air is out of the cuff, this arrow should start down here in this little box. If it is not starting in this box, it doesn't have to be exactly perfectly mid-box, but if it is not, if when all the air is out of the cuff, if this arrow here is not starting within this box right here, it is telling you your cuff is not calibrated properly, and it's not accurate sphygmomanometer anymore. And you can actually send these to a company and have them adjusted, but honestly, for what it's going to cost you to package it up, ship it, get it adjusted, and get it sent back to you, you can probably just go buy a new one. So generally, we tend to toss them after they, usually you're going to find hospitals will just get rid of them when it's no longer considered an accurate reading. So you'll see the 20, 40, 60, 80, 100, 120, 140, 160, 180, 200, 220. Hopefully your blood pressure doesn't go beyond 300. In between these, between the 20 and 40, this dark line here is going to be 30. So basically the way this works is each one of these little tiny lines right here, these little tiny ones, they're with 2 millimeters of mercury. So for instance, let's start at the 80, okay? This would be 82, 84, 86, 88, this would be 90, 92, 94, 96, 98, 100, 102, 104, 106, 108, 110. So everything's in increments of 2s. So I'm going to tell you right now, when you do a manual blood pressure cuff and you're telling me the blood pressure is 105 over 75, I am going to think you are absolutely just amazing. I mean, how on earth can you actually, when this arrow is coming down, when you're releasing pressure, you're going to be lucky if you catch the arrow, the even number on it. So to be able to tell me you could even read it, that it was in between those numbers, is just fascinating to me. You're going to end up with even numbers with a manual blood pressure cuff. So what we're going to do is when we put this cuff around the person's arm, we are going to pump up to between 160 to 180. You don't go over 180 the first time you take somebody's blood pressure. So you pump up the cuff between 160 to 180, and you're going to release it nice and slowly. You're going to release it. So this arrow that's pumped up to 160 to 180, you're going to release it. So it releases about 2 to 4 millimeters of mercury at a time. So 2 millimeters, each one of these lines is 2 millimeters. So it's going to release, so it's coming like this. Slow and steady. You don't want to just drop, sorry, didn't mean to do that. You don't want to just drop it real quickly. The arrow, you're not going to catch where the arrow was when you could hear the first sound. You don't want to go so slow that you're going, oh, am I hearing it? No, not yet. Okay, am I hearing it? No, not yet. Am I hearing it? No, not yet. You don't want to do that either, because their arm's going to be turning blue on you. Because literally, when you're pumping the cuff up to 160 to 180 millimeters of mercury, you're going to be cutting their circulation off to their arm. So we got to release it at a nice, steady, slow pace. You are going to be listening. When do you hear where was the arrow? What number is the arrow going by when you hear that first sound? That first boom, boom, boom. And it usually will start off softer and get louder. So it'll start boom, 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 and it gets louder. Okay, even those first soft sounds count. And then where was the arrow going by when you lost the sound altogether? So once the artery opens back up altogether, you are going to quit hearing the sound. So when we do a blood pressure, we're going to put our cuff. Now, one thing, we want our person to be sitting down, and we want their feet, if they're sitting in a chair, the feet should be flat on the floor. Their legs should not be crossed. I'm opening the arm up, and you want palm up. And the first thing you want to do is you want to find that brachial artery. Now, the reason I want to find the brachial artery is because I want to know where to put my stethoscope. Now, sometimes brachial arteries are hard to find, so remember it's at the bend of the elbow, just above the bend of the elbow, and in a little bit. And if I can't find it, I'm not going to stress about it. I know I'm going to put my stethoscope there, but it's worth looking for it. You want to try to find it, because if you can get your stethoscope right over that spot, you will hear it better. And everybody's anatomy is just a little bit differently. So most people, it's right, so it comes down the arm and it starts crossing across right here. So for most people, it's going to be right in this area. For others, it might be a little bit more over here. For some, it might be a little bit more over here. And if the person has larger arms, don't be afraid to press deep. It's not going to hurt them. Okay, so I can actually feel mine really well right about there. So that's where I would want my stethoscope. So when this blood pressure cuff goes on, now some of the artery marks, I don't know if you can see mine, it just has a 1 arrow mark. So I'm going to put that above the arrow. I do not want to have to put my stethoscope underneath the blood pressure cuff if I can help it. I actually want this to be up above that spot, because my stethoscope is going to go right over that spot. And I'm going to tighten this up, and this is going to be, I'm not going to really be able to do this too well, but I'm going to tighten this up so it comes around as tight as I can. You want to make this nice and tight. And you really cannot make it too tight. I mean, so just make it nice and snug, because as soon as you start Velcroing, it loosens up. This part of your sphygmomanometer can clamp right underneath here. So now you would normally be doing this to yourself. You're going to be looking at this angle to read it, but this way you can keep a better eye on it. That way it's not falling over. Now if you can't see it because of the angle of the patient, you can unclip it. They just unclip right here, and then you can just set it down so you can read it somewhere. When you're pumping up, this here, it's righty-tighty. So this turns to the right to tighten it, left to loosen it. So righty-tighty. And you're going to pump up in quick pumps. And you're going to keep pumping up till you get to 160 to 180. This is going to take forever because I don't have this on tight. And then when I want to release it, now I go to the left, and it's nice and slow and controlled, so the arrow is moving at that 2 to 4 millimeters of mercury at a time. So again, one little line is 2 millimeters, so it's moving 2 to 4 millimeters of mercury at a time. I'm going to be listening with my stethoscope that whole time of when do I hear the first sound go by and when do I not. So I guess I should show you that component of it as well. With your stethoscopes generally, they point out a little bit, and they point out towards the ears. So a lot of people try to turn them in like they're going to come in this way to the ears. This part actually points out to the ears. Before you use a stethoscope, you always want to clean off the earpieces and the diaphragm, the part that's going to be touching the patient, the part that's going to be going into your ears. So we're going to actually put this in our ears, and I like to just turn mine in a little bit and wiggle it down to my ears. The diaphragm part is the part we're going to be listening to for our blood pressure. So this part here, I would have this right here. I'd be holding this with one hand, and I'm going to be pumping up with the other. Now sometimes a little section of it will come underneath the blood pressure cuff, but ideally you really don't want the blood pressure cuff over this, because you'll hear as it's pumping up and releasing, you'll actually get some extra sounds of it rubbing up against your stethoscope. Your stethoscope actually turns, so this way here I can hear through the diaphragm. When I turn it this way, I can hear through the bell of the stethoscope. And for CNA, we're going to be sticking with the diaphragm for right now. When you move on for your nursing career, if you choose to, you will be learning how to listen to heart sounds with the bell. But for us, we're going to be doing stethoscope, or with the diaphragm. So again, the earpieces point out. They come in your ears after I've cleaned them. I've cleaned off the diaphragm. This is going to go right over that where I felt that brachial artery, because then I will be able to hear it better. Okay. I'm going to pump up to 160 to 180 millimeters of mercury, and I'm going to release it at 2 to 4 millimeters of mercury at a time. When I start hearing that first sound, that boom, 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 the very first sound where the arrow was going by, where that first consistent boom, 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 that's going to be my first sound. And then when I quit hearing the sound, that's going to be the second sound. Now the thing you have to remember is what you're doing with this. When I'm pumping this cuff up to 160 to 180 millimeters of mercury, I'm cutting off the blood flow down to the arm. So I'm cutting this blood flow down to the arm, and the first sound I'm going to hear is once I've opened up this artery, once I have opened this up enough, the bulb, and I've opened it up enough that the blood is starting to come through that artery again as it's pushing its way through, that is going to make the first sound. Once the artery's open all the way up and it's not pushing against resistance anymore, now I'm going to lose the sound. So sometimes I see people, they're trying to figure out where to put their stethoscope, and they put their stethoscope earpieces in, and they're trying to hear it without it even being pumped up or anything. You're not going to hear anything now because the artery is all the way open. It's not pushing against resistance, and so it's not going to be making a sound for you. You are not going to hear anything until you pump that cuff up, cut off the circulation, and then you'll start hearing sounds as you're releasing that cuff as the blood is starting to push back through. So there are many things that can impact our blood pressure. Age is one of them. As we get older, so blood pressure is low for a child. So we said heart rate was fast for a child, respirations were fast for a child, but blood pressure is much lower for a child. It gets to a normal range around 12 years of age. It starts getting into that normal range again. But we are going to be seeing our blood pressure again, normal systolic of 90 to 120, normal diastolic of 60 to 80. When you start getting older, sometimes a lot of our elderly population has problems with high blood pressure, hypertension, and which we'll be talking about in more detail after a little bit. But it is something that the 90 to 120, that's your normal range for most adults. So our elderly person, if they tend to run a little bit higher than that, and that is their normal tendency, and the physician is aware of it, and they may or may not be taking blood pressure medications, then that's fine. But if we take somebody's blood pressure and it's not in that normal range, we just want to touch base with the nurse and say, hey, so-and-so's blood pressure, this is the range, this is what I'm getting, is this okay for them? Okay, and a lot of times when we can go back at the chart and see what it's been running all along when we're documenting our values. Blood loss can lower the blood pressure. So when a person's bleeding severely, their heart rate goes up, but their blood pressure starts dropping really low. And that is also true for shock. Shock, when we talked about emergency procedures, shock is when the body is starting to shut itself down and it can't pump blood and oxygen everywhere it needs to go. So with shock, you're going to see heart rate go up and blood pressure go down. Activities can actually increase a person's blood pressure while they're doing the activities. Medications. Now, most medication, well, I shouldn't say most, a lot of medications will lower blood pressure. We have a lot of medications on the market for high blood pressure, for heart disease issues that can slow heart rates down, that can bring blood pressures down. But there are some medications that can actually raise it. So, for instance, if a person has an allergic reaction and you're giving them something like adrenaline to help combat the allergic reaction, that can make heart rate speed up, it can make blood pressures go up. Pregnancy tends to make the blood pressure go up because you have all that extra weight of the child and the extra blood volume that you're having to pump through the heart. And then pain. When a person's in pain, their blood pressure will generally go up as well. So some blood pressure terms. Hypertension, where the patient's blood pressure is consistently above the normal range. So a systolic. Now, I said normal was 90 to 120, but we don't consider it high blood pressure or hypertension till we're above 130. So systolic above 130, diastolic above 80. That is what we use for the term of hypertension. And the older guidelines used to be that we didn't consider something hypertension until it went over 140 over 90. But the new guidelines, the American Cardiology Association, the American Heart Association, the American Stroke Foundation, they're all using the values of a systolic above 130 now and diastolic above 80 as being your hypertension values now. So that means your pressure is high. Now, a one isolated reading, we don't consider that hypertension. A lot of people, their blood pressure will spike when they go into the doctor, and then it comes right back down to normal. So we look for trends. So we usually track a person's blood pressure for a while, and we see if it's consistently running high, then they will try to do something about it. Hypotension, so hypo is low, tension is the pressure, so low blood pressure. A systolic below 90, so 90 is normal, so below 90, diastolic below 60. And you guys, if even just one of those values, so a systolic above 130, but let's say your diastolic is still normal, so let's say the person's blood pressure is 134 over 78. That is still considered high blood pressure. Or for low blood pressure, you have a blood pressure of 92 over 56. That would still be considered a low pressure. Now, low pressures, we don't usually treat them unless they have symptoms with it. So if they have low blood pressure because they're bleeding, they have low blood pressure because they're in shock, then that's definitely something we have to take care of. But some people just tend to run to the low side. Orthostatic, it's actually orthostatic hypotension. It's a temporary fall in blood pressure when a patient rapidly moves from a lying to a standing up position. So when you are laying down and your blood is fairly distributed evenly through your body, When you go to stand up, you have valves throughout your body, throughout your blood vessels. So you have valves that kind of close off, so it keeps the blood from dropping from the torso and from your head all the way down to your legs. It keeps your body even and distributed throughout your body. So when a person is, they get up too suddenly, if those valves aren't closing properly, then the blood pressure can drop too quickly out of their head and make them feel dizzy and lightheaded, and their blood pressure can drop with it, and they can actually pass out. It's a huge fall risk. And it does happen to our elderly population quite a bit, because as a person gets older, the blood vessels are not as, the blood vessels do not work as well, they're not as elastic, and sometimes those valves don't shut off properly. So an elderly person has a more tendency to orthostatic hypotension. And if they have orthostatic hypotension, it makes them a huge fall risk. So it's something that we want to keep in mind. So we do not take blood pressure in an arm that has an IV infusion, an arm cast. If they have a dialysis site, and a dialysis site, it might look like a big, thick, ropey vein. It's really big though, and really thick and ropey, and it's usually underneath the skin. And there will usually be a sign up above their bed that says, "Don't take blood pressures in, that arm." Very dangerous to do that. If they've had breast surgery, if they have had a mastectomy where they've removed the breast tissue, a lot of times they take out the lymph nodes that are right around that area, and they'll have what they call lymphedema, where they start having swelling to that extremity, and it's very uncomfortable for them. So if they had a mastectomy on one side, we take blood pressure on the other side. If they have a bilateral mastectomy, we can actually even teach you how to do a thigh pressure. And some people will do wrist, they'll do blood pressures in the wrist. They did a really big study on wrist pressures, and most of the studies are showing that they're really not quite as accurate as a regular blood pressure. But you will see sometimes nurses opt to do that over a thigh pressure. And if an arm is injured, if they've had surgery, if there's some kind of injury to that arm, of course we would want to avoid doing it. So the term orthostatic hypotension occurs when the blood pressure drops significantly. We said when the person goes from a lying to a standing position. You see this sometimes with our elderly patients because we said their blood vessels don't shut off as good as they should. But you also see it with dehydration. If you've ever had the stomach flu, or you've had, you've been throwing up a lot and you haven't been able to hold fluids down, and you get up real suddenly and you feel kind of lightheaded and dizzy, it's because you're dehydrated and you're having orthostatic hypotension because of it. So blood loss, dehydration, and our elderly population also can happen after a lot of pain medications. Narcotics can do this. So think about an elderly person who's getting pain medication, and we said they already stay in a slightly dehydrated state. It's one of the reasons why they're more prone to falling when they get up, and especially if we get them up too quickly. So when we're checking for orthostatic vital signs, and sometimes the physicians will order, do orthostatic vital signs, then you will check heart rate, respiratory rate, and blood pressure, and you check it while they're laying down. So they're laying down, you check their vital signs. Then you sit them up and you wait 3 minutes. So you sit them in a sitting up position, you wait 3 minutes, and you check it again. Heart rate, respirations, blood pressure. And then you stand them up and you wait 3 minutes and you check heart rate, respirations, and blood pressure again. And if your blood pressure has dropped more than 20 millimeters systolic or 10 diastolic from that lying position to the sitting, or sitting to the standing, or their heart rate has increased by 20 beats per minute. So if the blood pressure's gone up dropped more than 20 systolic or 10 diastolic, and if the heart rate goes up 20 beats or more, it's an abnormal sign. It means they're orthostatic, and it means they're going to be more prone to falling. And so we have to keep that in mind. Okay, the electronic machines, there's advantages and disadvantages to these machines. As far as an advantage, of course, they have Doppler sounds to them. When you put the blood pressure cuff on and you press a button to take the blood pressure, it will pump up as high as it feels it needs to, or it'll pump up a certain part higher. Usually the machines will pump up at least 30 millimeters of mercury higher than what the blood pressure is going to be. Some of those machines just pump up really high, and then it's going to start releasing it. They're really actually very accurate measurements as a general rule. and they have Doppler sensors in them, so it can actually hear it. So sometimes if you check a manual blood pressure and you're like, wow, I'm not 100% sure what I heard, you can recheck your blood pressure over in the other arm, or you can actually recheck it in this arm. So let's say you check my blood pressure in this arm, and you pump up the blood pressure cuff, and you release it too quickly. You're not really sure you caught the first sound. What you want to do is you deflate it completely, and you wait at least a minute. So you wait a minute, okay? And then you go ahead and you can pump up and do it again. Now, a lot of people think, well, why would I want to wait a minute? I'll just take it off and put it over here. But by the time you find the pulse, get the blood pressure, get everything set up, it's going to be probably a minute anyway. So your choice. You can either wait a minute and recheck it in the same arm, or you can move it over. But after 2 times in this arm, if you still aren't hearing it, you can move it over to this arm. Or what a lot of nurses will do, if they're not sure they're hearing it correctly, they'll get that electronic machine out and they'll use the electronic machine because it has those Doppler sensors. I don't get overly alarmed if I check it with an electronic machine and it's a little bit higher than what I got because it has those Doppler sensors to it. Sometimes it'll be pretty, it may even be the same value, but you have to remember that the blood pressure is a constantly influx type of pressure happening. So you can check somebody's pressure and check it again in 5 minutes, and check it again in 5 minutes, and check it again in 5 minutes, and you're going to get a different reading every time. But it'll be within a range, generally, usually a range of each other. So they are fairly accurate. They will take blood pressure and pulse at the same time, though with this machine, it is not going to tell you if the pulse was regular or irregular, and it's not going to tell you if so it's not going to tell you if it was regular or irregular, and it's not going to tell you if it was strong or weak, but it will give you the reading of it. And the disadvantage of it, though, is that machine has to be cleaned in between each person. So what a lot of facilities are doing now is they actually make disposable cuffs now. So you can assign a disposable cuff to each patient, and then you just clamp. There's a little quick release that just the tubing from the machine just goes right into the quick release of the disposable cuffs. So you don't have to worry about wiping the equipment down each time. Even with the manual ones, we need to wipe it down in between each patient. So we would want to take a Sani wipe or some some sanitizer on a paper towel and wipe it down in between our residents. Same with those earpieces and that diaphragm of that stethoscope. We cannot use these electronic machines if we're going into an isolation room. Okay, that is, you do not ever want to take these electronic machines. If it goes into an isolation room, it's not just the cuff that has to be sanitized. The entire machine has to be sanitized before it can come out, and so we never want to do that if we can help it. And let's go ahead and take a quick break here.